Rajaram?
Yes, sir.
Yeah, can we start now?
Yes, sir. You can start now, sir.
Okay. Good morning, students. On behalf of Lotus Hospital and also the Surgical Forum, Indian Association of Gastrointestinal Endosurgeon is the largest laparoscopic association in India, and I'm actually the honorary secretary and also now working as a consultant surgeon. Many of you might know that I am working as a surgical gastroenterologist and endoscopic laparoscopic surgeon in Lotus Hospital, Europe. And as you all know, people from Perundara Medical College, I'm actually a graduate long time ago, 30 years ago, as an undergraduate, postgraduate from Coimbatore Medical College. So today we are going to start our journey in the online to understand what is important as a final year to pass the examination, because all of us are suffering from this COVID-19, because COVID-19 has not only caused economic impact and also disturbance in your social life, but also, as you can see, we have a lot of problem with our Rajaram. Can you put the mute all the audios, please? Rajaram?
Yes, sir. I will put it.
Including yours, I think there is a lot of disturbances coming. Keep everything mute for next half an hour or so. Thank you. So because of this COVID, I think that brought me more close to you all students now. So I thought of sharing my knowledge so that it'll help you definitely to get through this final year MBBS without even able to attend the on-site examination of the patient and also management. So our aim is very simple. You need to spare at least 30 Sundays with me. That is the requirement one. From 11 o'clock, 12:30 or so, roughly. And it is purely voluntary. And I've sent the communication to a lot more people. And even if you have some friends in other medical colleges anywhere, not only in Tamil Nadu, other states also, they are quite welcome to join. As you know, if there are more than 100 people, you can ask them to join in the YouTube, which is going live. The only difference in the YouTube is, of course, they may not be able to interact verbally, but they can always use the chat box to write a question. So if you have any questions or any concerns,
So you have to unmute, sir. Sir.
okay.
Yes, sir. Yes,
I have done that. Now you are able to hear me?
Yes,
right.
Sir.
Okay. Let's 30 minutes. Don't disturb any, don't make any changes now. Okay. Right. Now I'm going to have Rajaram, my administrator and manager, to help me at the other end. And the students, you're all muted because then you'll have less disturbances in your voice. So let me go without disturbing for the first set of few slides. Then I'll give you time for interaction. During the time, you'll be unmuted. You can ask some questions, or even during my talk, you can write your questions, concerns, some areas where you want clarification. There's a chat box, write it so that I'll be able to answer as we go. See, in this particular 30 modules, I'm going to start from esophagus, walk our way to stomach, then small bowel, large bowel, then liver, gallbladder, pancreas. Then we'll go out of GIT to breast, hernia, thyroid, vascular system, like that. Depending upon the time and also the interest shown by you all, we'll be able to go to various systems in what we call symptom-based approach. I have already seen the success for our teaching methodologies because of the 4 important reasons I want you to adapt. Of course, the first one is symptom-based approach. Very, very important if you want to be a good clinician. What I mean, see, for example, tomorrow, you may know everything about CA esophagus, everything about CA stomach. But what you need to know as a clinician or a general practitioner is, if the patient walks in, he walks with a problem or a symptom like dysphagia, dyspepsia, diarrhea, or constipation. From that, you need to guess your diagnosis, and then you have to know about the patient. So it is basically, it is a patient-based approach that is called a symptom-based approach. Very, very important. Especially, you should be a very good historian so that you are able to get into this is going to be the likely organ affected, like esophagus, stomach, from the likely pathology. That is, from the history, you should be good enough to make what I call an anatomical and a pathological diagnosis. I always used to say, if you want to be a very good surgeon, you need to be very good in anatomy and pathology. See, for example, if you want to be a very good in MD, for example, if you want to do MD rather than MS, you should be very good in your biochemistry, pharmacology. It's very, very important. Of course, physiology to some extent. So, depending upon, so as a surgeon, as you can see in my slides, a lot of explanations will be given about the anatomy. Wherever is required, stress on the histology, macroscopic anatomy, pathology. So pathology, anatomy are like two eyes of a surgeon. Next important thing is template-based approach, because every one of us, we learn. Like, for example, Hamilton Bailey used to be the book of choice during my tenure. Now there are lots of notes from Indian authors. There are a lot of international authors. Which one to read? Because each author has their own style of presentation, as we can see. But as a surgeon, as a beginner for you, for example, as a student, you have to, what we call, visualize anything, not memorize randomly. Because when you memorize, it's a recent memory, you'll usually tend to forget. So what I mean by visualization, you have to imagine as if a carcinoma esophagus patient is sitting in front of you. The best way is, imagine you have seen a patient a few weeks ago, a hernia patient, or a patient with a carcinoma esophagus coming with a dysphagia. You remember that patient, or you at least imagine a patient, how a carcinoma esophagus patient will be looking like, emaciated look, because he had nothing to eat for the last 6 weeks because of his dysphagia. Like that, visualization is a key. So I am going to give you a template on which you put your essay, like introduction, then patient's etiology, patient symptoms, signs, investigation, treatment, outcome, and then conclusion. Like that, we need to have a template-based approach. Very, very important. The next important thing, of course, is a keyword-based approach. What we mean by keyword-based approach means you have to learn, when I'm giving a discussion, a key important words. I'll say where and when it is required. That is that you have to think like a surgeon, because surgeons, they be like some words. So those words I'll stress here and there. You just take them down in a small pen and pad. Always keep a pen and pad with you now as we go from now to the class, because you have to take a notes. Even though everything is now available online, even this particular lecture may be available in YouTube, nothing like your own notes. Today's 1 hour lecture should be like 3 pages in your notes. That is the best way. Just a day before your examination, you just go back and see the notes. All right, Dr. Ishramurthy has given me all this gist on this. I'll follow this. So within 24 hours, you will be able to review all this 30 modules in about 2 or 3 hours time. That's the key importance of having a pen and pad approach. So I ask you all, if you haven't done already, try to go and grab a pen and pad. Keep writing. I'm sure some people are very keen taking notes. I'm very, very strong supporter for such way to learn, because you have to take it like a serious writer in order to learn surgery, or for anything for that matter. Rajaram, keep muting everybody as we go, because there are some disturbances I am observing here in my end. Keep yourself, okay, keep it.
Monitoring, sir. Yes.
Okay. Coming to the template, I already said this particular template is going to be used for you for the next 1 hour. What do you mean by the template? Any topic for that matter can be asked in essay, as an essay, as a short notes, or as an MCQ, or maybe in the Viva, or in the bedside when we are going for the war rounds. Anywhere, this particular piece of information is going to be useful. So you put the information in the right box, like etiology, or pathology, or patient symptoms, or what signs you elicit in a patient with a CA esophagus, investigation, blood investigation, X-ray investigation, like that. We put them in the right box so that same template can be used whether you read a CA esophagus, CA stomach, CA gallbladder, or even colon. So that's what we are going to follow. So once you become a follower of my class, this template going to be, it'll just become a habit for you, and you write your own book. That's the very important thing I want you to go. Don't go by any books, because books, each one have their own style, and you may not know which one is an important one, because it is not the lack of information where the undergraduates suffer. It is too much information. You're not able to filter. You don't know which is important for your level, because there is a thin line between postgraduates, undergraduate surgery. So it's very, very difficult for you. So I speak for you as an undergraduate. This is probably the essence you need to know. If you know more than this, well and good, but I think this is the bare essence, and I put the whole thing in a single slide at the end. That is a 6 or 7 line essence. That is the very important lifelong message. So these are all the small mini introduction I like to give before we go into the module 1 today. That's about 60 to 70 minutes it will run, because from now on we have non-stop 60 slides. That is, I am going to take you. You have to imagine I am standing, or somebody like a lady or elderly man is sitting in front of you with a dysphagia, and you presume him as a case of CA esophagus, or maybe a case of achalasia cardia, or it may be a child with a foreign body esophagus, or even a young girl with a corrosive injection 3 weeks ago. So these are the 4 cardinal cases, case capsules away, what I say, of a dysphagia. How will you take an history? Let me go through it. So approach to dysphagia. When you have a case of dysphagia, look back in your physiology book. When you take a swallow, for example, all of you, I hope you had a breakfast this morning, you might have had, and when you eat the breakfast, it goes into the oral cavity, mastication, your teeth, your tongue muscles, everything helps to push it to the pharynx. Once the food is in your pharynx, you know 3 things happen. That is, the nasopharynx closes, then the cricopharyngeal region, that is, opens, and the larynx closes. Closure of larynx, laryngopharynx. In other words, the airways are closed. So there is no regurgitation. There is no spillage into the airway. So the cricopharynx just opens that time, and food goes into the esophagus. From there, the esophageal phase of swallowing happens. And thanks to the powerful peristalsis of the esophagus, it goes in. As it reaches the lower end of esophagus, it dilates. Relaxation of the lower esophageal sphincter, then it lets the food go into the stomach. So in other words, esophagus is just a transit organ. Stomach is a reservoir and a mixer. Digestion happens only in the small bowel, and all unwanted food are eliminated after reabsorbing the water and essential vitamins in large intestine. That is, in essence, the physiology of GI tree. So like that, you need to understand the physiology and also to some extent anatomy from surgeon's point of view. For example, for understanding the esophagus, all of you know the numbers are very important. I'll tell you 3 numbers for the rest of your life. Number 50, 25, and 40. What do you mean by this? That is, from your incisor teeth, we put the endoscopy when we do the endoscopy. So from the incisor teeth to your cricopharynx, that is, the distance is about 15 centimeter. In other words, the esophagus starts only at level 15 in your endoscopy. And 15 is the level of cricopharynx. And that opens, the food goes in. Then 25, what is 25? That is one of the narrower portion of the esophagus in the mid portion where the arch of aorta left bronchus crosses. Because foreign body sometimes gets stuck in that region. That's why when we discuss foreign body in the child, it may stuck either in the cricopharynx. Next stoppage, maybe like from the bus from here, from Europe, it goes to Avenasi, like a stoppage. Here it is the stoppage. Next stoppage is 25 centimeter. The next stoppage is 40 centimeter, that is esophagogastric junction or a Z line. That is squamo-columnar junction. As all of you know, the histology of the esophagus is lined by squamous epithelium, whereas stomach, beyond stomach, small bowel, large intestine, and also rectum, excluding the anal canal, is lined by what? Columnar epithelium. In other words, the whole GIT, but for the two ends, that is upper end, esophagus, lower end, that is anal canal, both esophagus and anal canal are squamous. So cancer there is squamous carcinoma. Rest of the things are columnar. Cancer there is adenocarcinoma. Very simple. Remember, never forget. Coming back to the numbers, 50 esophagus starts, 40 esophagus ends. So the length of the esophagus for all of you is 25 centimeter. Okay, the length of the esophagus is not 40 centimeter. It is 25 centimeter actual length, but if we measure it from incisor, then it becomes 40 centimeter. Right. Coming to your patient, if you have a patient with dysphagia, the first question you ask is, how long, madam, you have dysphagia? Some days, doctor, I was okay till yesterday. I went to a restaurant yesterday night with my son. I had something to eat. Since that time, I'm not able to swallow well. So that means some food is possibly stuck inside the gullet. That is an acute onset dysphagia. Other patient may be saying, a 6-year-old man, doctor, I had problem for the last 3 or 4 months. I have been telling my son that I'm not able to enjoy my food like I used to. I now able to take only coffee, tea or something. I'm not able to eat any solids. If people make some non-veg, I can't, because I have to refuse, because I feel a sticking sensation in my throat. And my son also noticed I am fading away. I lost nearly about 6 kg in the last 2 months. So there is a typical history in a patient, an elderly patient who is having a progressive dysphagia, a chronic progressive dysphagia, initially for both liquids and solids, later only for solid. That is a classical description of a carcinoma esophagus, which is a mechanical problem, an obstruction to a tube. Esophagus is a tube. Ureter is a tube. Bile duct is a tube. All these tubes can get obstructed because of 2 problems, neurological problem or mechanical problem, because of the peristalsis obstruction, because of the tumor obstructing the lesion, the progress of the food. So this is a typical progressive dysphagia in elderly. So acute and chronic. In malignancy, it is progressive. Whereas in some conditions, for example, achalasia cardia, a classical condition, a typical patient, I'll tell you, is a middle-aged person will tell you, doctor, I've been having some sort of difficulty in eating. What I mean by is, I eat some good days, some days, especially I come to some, go to restaurant or I come to some marriage function, if I sit in the first pandi, then I start eating, I have to drink liters and liters of fluid in order to digest the food. So it takes nearly an hour. So I have to sit in the first pandi, then get up in the last pandi or the first sitting and the last sitting in the dining hall. That's what they used to say. Why? You may imagine. Because in achalasia cardia, it is not a peristalsis, it is not a mechanical problem. It is the neurological problem, because the peristalsis is not there, because there is a weakness of nerves. The failure of the lower esophageal sphincter to relax. Because of that, what will happen? The esophagus becomes dilated, fluid filled, and when you eat, food goes in, and the food will go slowly like all the heavy things will go down in the water column, and it opens the sphincter, it alone goes in. And once the food goes in, the fluid also goes to some extent. So the fluid is less now. The tank is now half empty. You have to fill the tank. So increase the hydrostatic pressure in the esophagus to again put the food down. In other words, only the pressure in the esophagus pushes the food down, not the peristalsis of the esophagus, because there is hardly any peristalsis in achalasia. So there is a very typical, in other words, patient has to drink liters and liters of liquid. So they feel, doctor, I have more difficulty in swallowing, so I have to drink a lot of liquids. That's what they typically say. And they usually say it is intermittent, because they always try to recollect on some festive or some going to the marriage functions, things like that. But one thing is very certain, these people, because they have a fluid-filled esophagus with a dirty fluid in the esophagus, whenever you see such patient coming near you, you can have a smell, peculiar smell coming from them because of the fluid there, with the dirty fluid. That is what we call halitosis. So halitosis is a very important sign you may have to elicit in a patient with achalasia. And also, achalasia patient, when they lie down, imagine all the fluid in the esophagus, because it's not able to go down into the stomach because of the failure of the lower end of the esophagus to relax, they spill over. What will happen? It spill into the lungs in the night. So they cough at night. Physician with a recurrent chest infection. So cough at night, nocturnal cough, recurrent chest infection to the physician is an indirect indication. See, sometimes the patient need not walk into the gastroenterologist. They can go into the pulmonologist. Like for example, a thyroid patient tomorrow, they need not come to an endocrine surgeon. He can go to a dermatologist with a dry skin. Mixed edema patient may have a dry skin. He can go to the dermatologist. Or a mixed edema patient may have a menorrhagia, can go to the gynecologist. A mixed edema patient can go, because of their always feeling sleepy, to the psychiatrist. Or thyrotoxicosis patient go to the psychiatrist because of the insomnia. So like that, in other words, some patients may not know where to go for seek for. So as a clinician, as an undergraduate, it's your duty to have a complete global history taking. Acute or chronic dysphagia, progressive, solid or liquid. The fourth important, very, very important is called painful dysphagia. Yeah, very important keyword. I'll stop here and tell you, write down wodenophagia, because your keyword vocabulary, I will be telling at the end of the 30 classes, close to 200 keywords. These are what we call the surgeon's dictionary. Whenever you elicits symptoms from the patient, you have to elicit, like a patient has a painful dysphagia. But when you explain to me, to the surgeon, you have to tell, sir, this patient has a typical history of wodenophagia. Then I like, oh, that particular student knows my language. So that is what. So there is a difference when you elicit, when you utter in the presentation. So it is a sign. What is the sign? Is wodenophagia is the word we like as a surgeon to hear from you as a student. And associated symptom, if you don't eat for so long, of course, you'll be skin and bone. They'll be emaciated. Like weight loss will be significant. And if you force them to eat, they'll be vomiting. And also because if there is an underlying malignancy, they may even have anorexia. So take a good history. And then you can see there are Humpty number. There are actually, if you see, there is a French index of differential diagnosis. For each symptom, if you go by the French index, there is a book. Actually, there is a 1000-page book. I used to read those days, but that is not widely available. I'll tell you just there are 10 common causes for dysphagia. That is enough for you as an undergraduate. For that, the simple rule again is to imagine the esophagus like your ureter, your bile duct, your bowel, like a small bowel, large bowel, all tubular organs. Imagine there are cardinally 3 different causes: intraluminal causes, in the wall and outside the wall. Intraluminal means inside the lumen. Some food bolus like a chicken meat, or a foreign body like a denture accidentally swallowed by an elderly person, or a coin swallowed by a child. So that can cause blockage to the passage of fluid, food. In the wall, this particular esophageal wall can be diseased by a benign process or a malignant process. Carcinoma esophagus is common, but it can be also benign, like at the upper end of the esophagus, that is at the 15 centimeter level at cricopharynx. There is one important syndrome, Plummer-Vinson syndrome. Take it down. Plummer-Vinson syndrome, all of you know, a classical iron deficiency anemia. Patient will present with kalynokia, spoon-shaped nails, glossitis, and they'll have iron deficiency anemia, and they'll have dysphagia, mainly because of presence of a small web at the postcricoid region. So we have to treat not only the anemia, but also endoscopically, we have to treat this post-cricoid wave. And incidentally, it is a precancerous condition. Next, of course, is a mid-esophagus, where sometimes a corrosive ingestion, like if you ingest acid or alkali, it can cause narrowing of esophagus at a later date. In our country, some other stricture like tuberculosis also can happen, but corrosive is the commonest cause for stricture. And the last one is the lower end of the esophagus go for narrowing or benign process because of the reflux of acid, because of what we call a gastroesophageal reflux disease, GERD. So because of the GERD, patient can also have stricture of the lower end of the esophagus. So these are all the benign causes. Whereas the commonest cause, as far as you are concerned, especially a patient with a progressive dysphagia, is of course a malignant esophagus, that is especially in an elderly, smoker or alcoholic. Men more than women. That is a very important, because there are only certain cancers are more common in women. Obvious ones, of course, you all know. Take down CA breast and CA cervix. Everybody will know. CA cervix, almost all, 100%. CA breast, 10% in male breast, 90% in the female breast. Whereas thyroid, for example, more common in women. That you have to understand. Whereas here, esophagus, stomach cancer, almost 2/3 of them are going to be male. So most of the GI cancers, for that matter, is more common in men because they are mostly smokers and also use alcohol. Next, of course, is outside the wall, there are some peculiar condition, Zenker's diverticulum. Probably when you see the applied anatomy, they might have described you what is Zenker's diverticulum. You discuss with you friends there. I'll give you a little milliseconds. If any of your friends are able to, this is otherwise called a pharyngeal pouch. You are right. See, for example, your cricopharynx muscle is actually having two portions of the cricopharyngeal muscle. So if there is an incoordination between these two, the oblique and circular fibers of cricopharyngeal muscle, okay, then there will be a outpouching of the mucosa in the posteriorly in the cricopharyngeal level that causes the Zenker's diverticulum in the upper end of the esophagus. It will present like a small pouch in your neck, especially on your left side, and that when it is food filled, patient has to actually press this in order to empty the sac. It is more predominant in some birds, so they have to empty it too, so the food will again come into the esophagus. So this is a very peculiar rare condition, pharyngeal pouch. But more common for you is mediastinal lymphoma or retrosternal goiter. These are the two mediastinal mass which is outside the wall causing an obstruction, like large heart also sometimes, left atrium. All of you remember mitral stenosis will cause left atrial hypertrophy. That will cause obstruction to the esophagus in the middle part. So these are all the outside the wall. But if you remember one condition for dysphagia as far as the elderly is concerned is CA esophagus. Very, very important. One cause for an adult is a corrosive stricture or a peptic stricture, benign cause. And one cause for a child is a foreign body, almost always. Okay, coming to the next one, that is esophageal cancer. That is our next 20 or 25 minutes discussion. Let me just see, is there any questions or anything? Rajaram, how many people have joined now, roughly?
Sir, 100 people are accommodated in this group, sir.
Okay,
In YouTube,
good.
yes.
Okay, I think we'll carry on. Students, I'll be breaking now and then just to give you some breathing space. I'll be stop sharing like this. It is just to make an interaction and also get to know where we are. And I actually will appreciate, don't hesitate. Hesitation is a weakness of most of our Indian students. Write some chat box. Even if you're not able to interact now verbally, I'm sure I'll give you some time to share with your questions, but at least write down. Don't unmute anybody, Rajaram. Just let them chat in the chat box. Write some questions, write your comments, how we are doing, or you want me to go slower than what I'm doing, I can do that slowly. Okay, this is the learning process, not only for you and also for me. Okay. So let us go back to the CA esophagus, which is the most important essay for you. Sometimes it is important in the viva and also in the board rounds, when you have a carcinoma esophagus, invariably I'll ask some questions to my residents, and these are the bare essence I like them to know. Okay, let me go one after other. As I said, everything should come with the introduction. See the template I am going to use. What is the introduction? Carcinoma esophagus is one of the common GI cancer with a dismal prognosis. Dismal means poor prognosis. There are 3 or 4 cancers I would want you to remember, which is having a very poor prognosis. CA esophagus, CA stomach, CA pancreas, CA gallbladder. All 4 in the GAT is very, very bad prognosis. Why? Because their 5-year survival is less than 10%. Whereas CA stomach, little slightly better out of them, but CA colon, for example, is much better. So that's why if you have a colon cancer, you have to relatively happy. I'm not telling you. For example, if you have a CA thyroid, that is one of the malignancy which is very good prognosis. So even in the adversity, there is a little bit of, you have to pray that even if I get a cancer, better I get a good prognostic cancer like a thyroid cancer. Same way, whereas CA esophagus is one of the cancer with a dismal prognosis. The only way we can get rid of this or get a curative treatment for your patient is by early index of suspicion. If a patient says some difficulty in swallowing, your grandmother, father is telling, immediately submit them for endoscopy. Early endoscopy, early chemoradiation and treatment is the only way we can improve the survival rate. Because as you can see, the incidence in most of the countries around 10 per 1 lakh, whereas the common 2 countries where it is so common is one is Iran and China. Here is the importance of countries. Some tumors are more common in some countries. I'll tell you now. CA esophagus, Iran and China, you know now. Stomach, I'm sure you know, some of you already, Japan. And colonic cancers, Western countries, one country if you want to remember, USA. Why? Because that's where there's a screening colonoscopy for early detection of colonic cancer. Okay. CA breast, almost all Western countries. One country you remember, there is United Kingdom. Why? Because in UK, they do a screening program from age 55 for mammogram. For all, because there is, wherever there is a high prevalence of a particular cancer, they have a screening program. So any screening, see, for example, you may be asked, what is meant by a screening for cancer? Then you write these particular cancers, prevalent countries, what screening program they do. For example, Iran and China, because they have a carcinoma esophagus, they have a screening endoscopy, they do what we call a balloon cytology. I'll tell you later what is balloon cytology. In Japan, carcinoma, stomach is common, they do an endoscopy, and also they used to do a barium study, but nowadays barium is not very sensitive. In US, I told you colonoscopy for a CA colon. In UK, they do a screening mammogram because CA breast is so common. What about our country? Any guess, students? Yes, if you said it is a CA cervix where we do pap smear, absolutely you're right. That is the one screening program we do almost always. Rest of the things we do only when we have a high index of suspicion. Age group, I said, male predominance. Next, in addition to that, always, if you have, like for example, in my Erode, for example, Perundarai, there is high chance of any malignancy because industrial plays. Why? We may wonder. Because of the chemical problem or contamination of the environment, whatever. So you need to know the risk factors or environmental factors for cancer. That you might have read in your pathology, but here is a carcinoma esophagus, a mnemonic A, B, C, D for you. Plummer-Vinson syndrome, that is anemia, there is iron deficiency anemia in a patient with a Plummer-Vinson syndrome with a post-cricoid stricture. It can, if it is overlooked, can turn into a post-cricoid cancer. Barrett's esophagus. What is Barrett's esophagus? A patient with a reflux of acid in the lower end of the esophagus, his squamous epithelium will go into metaplasia into columnar epithelium. That columnar epithelium will change into a specialized intestinal neoplasia, that is epithelium. That is the next important, that is dysplasia, it will become, then it becomes a cancer in situ, then cancer. You know the sequence. So metaplasia, dysplasia, cancer in situ, cancer. It takes time, but Barrett's esophagus is one of the commonest predisposing factor for developing an adenocarcinoma of the esophagus. Now itself I'll tell you, esophagus means, because it is squamous lined, you know it is squamous carcinoma. Exception, lower end of the esophagus. The reason, because of the Barrett's changes. How common it is? It is common in the lower 1/3, probably about 30% of the people will have adenocarcinoma in the esophagus. It is more common in Western countries because there the Barrett's changes are more common compared to our country. Corrosive strictures are more common in our country. So corrosive stricture can be a predisposing factor for a malignancy later. Any diverticulum, like pharyngeal diverticulum, Zenker's diverticulum, mid-esophageal diverticulum, or lower epiphrenic diverticulum. That is epiphrenic. What do you mean by phrenic? Diaphragm. Epiphrenic means above the diaphragm. So esophageal diaphragm, just above the diaphragm, is called the epiphrenic diverticulum. So they also can predispose to malignancy. Coming, I told you already, this is what you read in your pathology. The whole carcinoma esophagus is in one slide now. So first day it may take little time, tedious for you, but when we discuss carcinoma stomach, carcinoma small bowel, carcinoma colon, it will be easy because the template you know, then you will just fill in the blanks. Like macroscopy, microscopy, spread. You take it from me, all macroscopic tumor will have three predominant types. That is, the tumor, if you see cut, for example, you may see any surgeon when they operate, they like to see the specimen. They cut with the scissor and open the bowel and see how big an ulcerative tumor. So whether it is predominantly an ulcer or it is like a projecting into the lumen like a polypoidal lesion, or it infiltrates into the bowel onto the posteriorly even to the periesophageal tissue or even to the aorta. So infiltrative type. So there are three types of local tumor, any tumor for that matter. An ulcerative tumor which will bleed, proliferative tumor which will obstruct, and infiltrative tumor into the periesophageal tissue. Microscopically, I already told, squamous carcinoma in the upper 2/3 of the esophagus and adenocarcinoma because of the Barrett's changes in the lower esophagus. And one peculiar feature of esophageal cancer is what we call a submucosal spread. What do you mean by, if you have a tumor in the esophagus here, the tumor may be macroscopically here, but the tumor cells will go creeping, like as if the water is going underneath the tiles, creeping underneath. It will even involve seemingly normal looking bowel. The mucosa in this part of the bowel, esophagus, as you can see, may look normal because submucosal spread may be there. That's why whenever a surgeon resects the esophagus, they don't resect just the tumor. They have to go at least 5 centimeters above, 5 centimeters below. So if it is a 5 centimeter tumor, 5 centimeters above, 5 centimeters below, 15 centimeters of esophagus gone. 25 centimeter only esophagus. So nearly, if you have a 10 centimeter tumor, you imagine the whole esophagus, total or subtotal esophagectomy has to be done. That is the importance of submucosal spread. So whenever you have a tumor, how much you have to excise in order to have a local good cancer clearance. That is oncological principle. I tell you now, take down. Basal cell carcinoma, BCC, skin cancer in your face. There it is just 1 or 2 millimeter is enough because you can't remove 5 centimeter here. Squamous cell carcinoma in elsewhere in the skin or anywhere, maybe about 2 centimeter is enough. Whereas if it is in the esophagus or somewhere in the stomach, any tumor, adenocarcinoma in the stomach also 5 centimeter minimum. Whereas malignant melanoma, 5 centimeter optimum. Okay, so these are all rough estimate. It is only because that is the only way to have what we call tumor-free margin. Take down you will be able to understand this terminology later. That is, whenever we remove a tumor, for example, I am removing a esophagus, sent to the pathologist, pathologist will do what? He'll cut not only the tumor, but also the end of my specimen. Also see, my end of two ends of the specimen also is free of tumor. So that is called the tumor-free margin. Only then I can tell patient has no tumor inside his rest of the esophagus. The tumor-free margin is very, very important for prevention of local recurrence. It is a very, very important oncological principle at your level need to understand. Other important margin, or one of the important poor prognosis thing, we'll see the lymph node harvest. How many lymph nodes oncologist able to remove along with the tumor is also important for a local control. I'll discuss in the treatment part. Spread also, as you can see, it can spread directly here into the neighboring tissue like aorta, or somewhere it can infiltrate. Lymphatic is the commonest spread for any squamous cell carcinoma. Blood spread also through from the lymph node through the lymphovenous channel it can go, or directly through the blood, also like adenocarcinoma it can go. The first filter for most of the GI cancer tumor is always, because it is through the portal system, lower end of the esophagus. Also, if you see through the hemiesophagus system, systemic vein goes to the portal system to the liver. Liver is the commonest secondaries. Next, only the lung. Okay, unlike, for example, carcinoma of the kidney, which is the first filter. Pulmonary metastasis is the commonest one in the testicular tumor and also in renal tumors, or for that matter, breast cancer also, any blood spread tumor. Whereas here, through the portal system mainly, so it is a periesophageal tumor and also to the liver also. Next is coming a word about Barrett's esophagus. I hear itself. This is the gentleman, as you can see. Rajaram, can you hear me clear? Any disturbances so far?
No, sir. No, sir.
Okay. Okay, thank you. I'll just take it slowly for them. So this is Norman Barrett's. Norman Barrett's is a thoracic surgeon in UK. He observed there is some changes in the lower end of the esophagus. From normally, when you pass an endoscopy, the esophagus look very pale, not like a very pink color. See, the pink color of the lower end of the esophagus, they usually, because he is actually a UK surgeon, he described is like a color of a skin called salmon fish, salmon pink, SALMON. That is a very dark pink color, as of a cut salmon pink color mucosa, because this is the columnar lined esophagus. This is actually, because of the constant acid reflux, because of the repeated inflammation, it changes into metaplasia. Then because of some mutation, like a tumor suppressor gene mutation, goes for a dysplasia, then cancer in situ, cancer. And that's why Barrett's esophagus is a very, very important reason for your cancer in the lower end of the esophagus. Now coming to the symptoms and signs. Symptoms, what patient says. Signs, what you elicit as a student. Let us going into the symptom. I told you already what is the symptom. All of you just recollect. Progressive dysphagia, especially for solids, with a significant weight loss in a patient with an elderly man. This is the classical presentation. The rest of the symptoms mentioned here is only for completion. For example, some people, they keep on eating because, for example, if you offer 3 or 4 idlis to an elderly man, and if you force him to eat, he is not having difficulty eating, he keeps on eating, the food stays in the esophagus, it never goes into the stomach. And when he lies down at night, it spills over. Reflux symptom. Don't confuse this reflux symptoms to reflux symptom of gastroesophageal reflux disease. Here, because of the undigested food which is already in the esophagus, not able to go inside. That's a very, very important. So that's why what people say, they eat, then they vomit. That's what happened, most of the people. But the vomiting here is not a projectile vomiting. See, progressive dysphagia is a classical symptom of carcinoma esophagus. Projectile vomiting is a cardinal symptom of gastric outlet obstruction, very important. If you see a patient with a gastric outlet obstruction of the pylorus, what will happen is that patient, because he has a huge stomach, he can eat even 10 idlis. That afternoon, he'll go silently, put his hand into the mouth and vomit projectile. All the 10 idlis will come and then he'll go and eat again. He'll have voracious appetite. So that is keep on, because this result, he keeps on filling, emptying, filling. But here in the esophagus, he'll only fill, then it will spill over. That is reflux. That is not projectile vomiting. Very, very important to differentiate. That's why history taking is very, very important to differentiate which organ is involved and what pathology. Emaciation is a very important thing, because carcinoma esophagus, you know, the pathology is in the thorax. You won't be able to examine. It's not in the abdomen. So nothing much to see in the abdomen. So if you see a patient with the carcinoma esophagus, he is as if had no food for the last 3 months. How will it be? Skin and bone, indrawn cheeks, no wasting of muscles, anemia, okay, and sunken eyes. Classical thing, you can always see that. Sometimes they can have a lymph nodes, especially left supraclavicular lymph node. Yes, all of you, I hope you got it. That is the virtuous nodes, otherwise called Troisier sign. Very nice. Troisier sign or a virtuous node is one of the advanced sign. That is a disease of advanced spread. If there is a Troisier sign, why it is important? If you put a hand here in a patient with the progressive dysphagia, then I'll know this patient not only has a carcinoma esophagus, he has a inoperable or advanced carcinoma esophagus. That is the importance of clinical examination. You need not have an endoscopy or a CT scan for that matter. So clinical examination to large extent has to be very, very systematic. Coming to the examination of the chest, when you examine the chest, what do you do? Inspect, palpate, percuss, auscultate. Same way you do, write the findings. Even if you write, inspect, palpate, the heading alone you write, essentially normal. Sometimes patient may have signs and symptoms of pleural effusion in the esophagus. Well and good. Always you try to put the template on, because that's the way your case sheet is going to be when you are as a CRRI. Then examination of the abdomen. Again, inspect, palpate, percuss, auscultate, examine the groin, examine the rectum. So this is the completion of the examination of the abdomen. In abdomen, especially in a CA esophagus, if they have advanced CA esophagus, lower end, they may have hepatomegaly because of secondaries. They may have ascites, very advanced cases. But hepatomegaly and ascites is more common in CA stomach. Esophageal cancer may not, need not have any abdominal signs. So in other words, one single sign of esophagus is a patient who looks very emaciated. That's the only sign you will elicit. All you see is by investigation. Now this next 2 slides are going to be very busy, because I want you to have all the investigation in one single slide. That's the only reason. Otherwise, you can put. First day, as I said, first module, we are going a bit slow, because the headings also important and also inside also important. But when it comes to the stomach, when I say the heading, you should be able to give the answer, because you know roughly, if you visualize, you'll be able to tell. Hematological, most of the GI cancer, either because ulcer in the esophagus, because of what will happen, it will keep on bleeding, chronic anemia. Chronic anemia, what will cause? It will cause microcytic hypochromic anemia. So full blood count, patient have low hemoglobin, low MCV, mean corpuscular volume will be less than 70. What is the normal mean corpuscular volume? Note down, 70 to 90. Less than 70, microcytic anemia. More than 90, macrocytic anemia. Give example for microcytic anemia: iron deficiency anemia, thalassemia. 2, macrocytic anemia, B12 or a pernicious anemia. And second important thing, as you can see, anybody, macrocytic anemia, any examples for macrocytes? You think about it and let me know. Next is a biochemical reasons, where you will see is a liver function test. For example, a patient with the liver secondaries, they may have abnormal SGOT and SGPT. And radiological investigation, you have to go from a simple to more advanced investigation when you write. Barium swallow for undergraduates, very important. We do ultrasound, CT, and specialists like a surgical gastroenterologist. Sometimes they do also endoscopic ultrasound, and oncologist will ask for a PET CT. See, that's the way it's written. So you at your level, the basic thing we require for all of you, if you write all investigations if you know, and that's well and good. Any barium investigation, if it is an esophageal disease, barium swallow. If it is a carcinoma stomach, if a radiological investigation, barium meal follow through. If it is a large bowel cancer, barium enema. You got it. Like that you can manage. Ultrasound CT abdomen for everybody same way. Endo ultrasound, write it as it is. PET CT for all of them you write. Any cancer, PET CT, because that gives you the quantum of disease in a patient. Very, very important. See, for example, PET CT, what it does, from head to foot, you know how much of quantum. Lymphoma, cancer breast, you have to have a PET CT. Whereas esophageal cancer, gastric cancer, it is not optional, it is essential. Staging laparoscopy, optional, not essential. But it is nice to write all these things so you speak surgeon's language. Surgeon likes to say, oh, right, this chap knows everything what we do. But passing the exam, barium swallow and ultrasound and a CT is enough for you. Special investigation, very, very important for all of you. Carcinoma esophagus is diagnosed only by endoscopy and biopsy. That is the test of choice. Then when we operate these people, because esophagus where it is inside the chest, you have to do a thoracotomy. To do a thoracotomy, it is not a simple operation. Patient has to have a good cardiopulmonary status. So you need to do performance status. Like how will you test the patient's lung function? By doing a chest x-ray, pulmonary function test like peak flow test and things like that. Next, the cardiac test. What do you do? ECG, echo, or even treadmill for that matter. So all these things you write in all major cases like carcinoma, esophagus, stomach, pancreatic cancer, because that is what required from you. When you are a resident, have you done this? Because only if the patient is fit for anesthesia by having a good heart, good lung, as a surgeon, I can operate. So these are all essential investigation you have to write down in the examination also. Coming to the exam point of view, the one important thing all of you like to hear, already you might know, is a rat tail appearance in barium swallow. See, as you can see here, esophagus normal, and here there is a narrowing, a thin barium is going, and this is a tumor in the mid and lower esophagus, large tumor, causing narrowing of the lumen. This is what we call a shoulder, like your shoulder on either side, like this. This shouldering is very, very, if it is coming like a slope like this, is a benign. So if it is having horizontally like that, like a shoulder, then it is malignant because it shows there is a growth. This is in large bowel, it is described as apple core lesion. See, the word is different because the radiologists are funny people. They describe all the signs on food sign or animal signs, rat tail appearance, apple core lesion, bird beak sign. So better you remember all those things because not only the radiologists, but the surgeons are also very fond of these terminologies. So rather than trying to tell me, you just tell a rat tail. What do you mean by rat tail? It's a long, irregular filling defect. If it is very short, smooth filling defect like a bird beak, then it is achalasia cardia. Okay. Coming to the next one, this is the classical bird beak sign. See, dilated esophagus like a sigmoid colon with a small narrowing at the 40 centimeter end, like this bird beak is big. And even you can imagine like a bird, even if you draw a little eye and a thing, it looks like a bird, isn't it? Diving into the water, okay, diving into the sea. So it is a very, very classical appearance of achalasia cardia. So there are only two radiological signs it will be requested from you as far as the barium swallow is concerned. Rat tail, bird beak for rest of your life. Okay, one more rat tail is coming here, is a rat tail. But I told you already, the most important investigation is endoscopy. Here is an endoscopy I've done a few months ago. We are into the stomach, as you can see, rugal folds means you are inside the stomach. And when you see the endoscopy itself, that means you are looking at the fundus of the stomach. And we are coming, withdrawing the scope, we are coming back and back. Now we are examining the esophagus slowly. Now we are entering the lower end of the esophagus. Okay, the lower end of the esophagus is coming here, and then and you can see here the lower end of the esophagus, and there is a tumor here. This is a tumor. Okay, and again, if you see this patient, normal esophagus here, and you will see one more tumor here. See, there is one more tumor, even some friability, some tumor tissues also. So this is a circumferential tumor with the tumor tissue here. We have to take that bit for biopsy. This is about the 5 centimeter, whole 360-degree circumference of upper esophagus. So this patient has upper esophageal tumor, lower esophageal tumor. 2 tumor, 1 patient. That is a classical case of what we call synchronous tumor. There are 2 types of tumors sometimes. People having same time 2 different cancers, synchronous cancer. Metachronous cancer means you remove cancer today, 1 year or 2 years down the line, you develop another cancer in the rest of the esophagus. That is metachronous cancer, common in colonic tumor. If you do a right hemicolectomy, patient will present with the left side of the colon having a cancer. So like that patient will have. So these are the 2 terminologies. Take down synchronous, metachronous. You can see now I am taking a forceps, biopsy forceps. Take that bit, I told you already, taking a bit, see, I'm sure the upper end will show, definitely this is going to be, and actually it was a case of squamous cell carcinoma of the upper and lower end of the esophagus, which is the commonest cancer in our country at least. Adenocarcinoma is there, but it is more common in Western countries. And other investigation which we don't do, but the medical gastroenterologist might do, is an endoscopic ultrasound. It's only for a completion I am telling you. This is actually nothing but having an endoscopy and also ultrasound at its tip. See, normal ultrasound, what we do routinely every day, that is called a trans-abdominal ultrasound. Because abdominal wall is there between the organ and the ultrasound machine. So the sound wave may not go easily. Whereas here the ultrasound wave goes right on the bowel wall. So you are able to see mucosa, submucosa, muscularis propria, adventitia, layer by layer. What do you see in histology? In other words, it is the histology is seen by the radiologist. So that is the beauty of this investigation. So the endo ultrasound is making it possible for making what we call the T staging. See, all of you know also TNM staging, tumor, node, metastasis staging. The tumor staging you will be able to understand better by endo ultrasound. Because even in endoscopy, we will be only see the inside, what in the lumen, but we don't know how far it's infiltrated. But as endo ultrasound is good. But CT also will show, but the CT is good for the, not for the T stage, but for the N stage and M stage. What is N stage? Nodal disease and also metastasis disease. M stage like liver secondaries, lung secondary. That's why if you want one investigation to know the stage of the disease, TNM staging, which you will do, MCQ, endoscopy, endo ultrasound, CT scan, ultrasound, transabdominal ultrasound, MCQ, you have to write it is the CT abdomen, because that is the one investigation will give maximum information. So that's why we always say without CT, no patient to the OT in cancer patients. Okay. So this is a very advanced slide. Actual level not necessary. For prize exam students and postgraduates, they have to know the tumor staging. But if you read carefully, even for a beginner, it is not too difficult, because the same staging is for the whole GIT. Whether you like it or not, you have to read it for carcinoma stomach. So as well, you read it here. Tumor in situ, you know already. T1, 2, 3, 4. N0, N1, 2, 3. M0, M1. 0 means no tumor. Okay. Whereas 1 means only submucosa. What is the next layer? Muscle. That is 2. What is next? There is no 0. So periesophageal or adventitia next. That is T3. T4 is adjacent organs like a aorta. So for example, if neighbors are involved, imagine carcinoma of the stomach, okay, infiltrating the pancreas. What is the stage? T4, because it is already involving the neighboring or adjacent structure. See, for example, carcinoma of the stomach, just seen on the serosal surface. What is the stage? T3. So like that, you will be able to understand T1, T2, T3, T4. Easy. That is easy. For your level undergraduate, you know N0, no nodes. N1, 2, 3 means neighboring nodes at various level. Periesophageal and distal nodes and very distal nodes like infradiaphragmatic or cervical nodes. Like that, we can able to understand the extent of the nodal involvement. Because as you know, higher the stages, worse the prognosis. Okay. Coming to the treatment, we are coming to the nearly close to 50 minutes from our class started. We are coming to the most important aspects for the next 10 minutes. Then I'll go to the achalasia. So our duration of discussion now, after 10 minutes, I am going to give you a break for about 2 or 3 minutes for questions on CA esophagus. Then with your stamina permitting, my stamina is okay, then we'll finish the whole esophagus dysphagia, finish it for a day, we'll move on to the dyspepsia next class. So esophageal cancer or cancer for that matter, any cancer, our aim is twofold. If it is early cancer, like TNM staging, for example, T1 or N1, these are all early cancer, curative treatment. Advanced cancer, for example, T3, T4 or M1. See, imagine M1 means what? All of you know, liver metastasis. If you have a liver metastasis, how long you will have to survive? Median survival after liver metastasis is roughly about 6 to 10 months maximum, even with the palliative chemotherapy. So not even in a year. So you don't want to do a thoracotomy, esophagectomy, do a surgery. You only do a patient suffer and die. So there you don't operate, you palliate the patient. What is palliation? Symptomatic treatment. What is the symptom in this patient? Dysphagia. So what you want to do? You put something in the esophagus like a stent. So patient can enjoy the meal with their family and friends. Tomorrow, after the stent placement, he can have a little bit of, like not even the solid food, at least mashed potato or even idli or something. If he has a teeth, he can munch and swallow semi-solid or a sloppy diet or liquidized diet. He can eat. Palliation. How long? Until he lives. That is the best palliation. About 20 years ago, we usually palliate by doing a procedure. Even now you may know. Do you know the procedure's name? If anybody thought it is a feeding gastrostomy, well done. Feeding gastrostomy is the answer I was looking for. That is, you put a small tube in the stomach and bring it out. Okay, percutaneous feeding gastrostomy. Through the tube, you food half a liter of like a kanji or a Horlicks or a proteinous to drink, something like that. But that will not alleviate the patient's symptom because he'll have hunger. He doesn't like. You have to have the taste of the food. You have to enjoy your meal. So the one best palliation is putting a stent, make them eat, feed them through a tube, because tube gastrostomy will not improve the quality of the life. It will only improve the quantity of the life. Quantity means what? He may survive a bit longer, but he may not have a good quality of the life. So the very important thing is, when you do any palliation, in the palliation's aim is good quality of life. For that, take away the patient's symptom first. What is the symptom? Address the symptom. Dysphagia here. Okay. And treatment, as we can see, only 50% of the people we can remove by surgery. And even when you remove, there is a 10% of people can die because of the surgery. High mortality. See, for example, if I say a patient, if I operate today and 10% of you die, nobody will accept. Even if you know COVID-19, what is the mortality? Even in the worst scenario, it is 3 to 6%. So it is worse than COVID-19, the CA esophagus operative mortality. So nobody will accept that. Even in experts in a specialized center, it is about close to 5%. So you have to be very careful. In other words, we think twice before we submit the patient for surgical procedure. So that's why carcinoma esophagus, vast majority of them are either palliated or we do what we call primary neoadjuvant treatment. Chemoradiation is a key treatment. C for C, chemoradiation for CA esophagus. Remember that, okay? Next is, this is a very busy slide, but don't get worried about the slide. It's just to beginning, I am giving you all cancer oncology. One word very important for you to get a mark is, you write at the top for every cancer treatment is multimodal. What do you mean by multimodal? It is not just to consider surgery. Surgery, radiotherapy, chemotherapy. In surgery, it can be curative, like removing the esophagus with a 5 centimeter clearance. That means esophagectomy. If you remove the whole esophagus, then how the patient is going to eat? Very simple. You just mobilize the stomach from the abdomen, pull the stomach into the chest, anastomose to the pharynx. So stomach, that is otherwise gastric tube, is used as a esophageal conduit. That is called a conduit. So esophagus, it is called a neo-esophagus. Stomach acts like a new esophagus. So that is the thing. Resection of esophagus, reconstruction of the esophagus using the stomach as a conduit. If stomach is not available or not appropriate, you may use large intestine, colonic replacement. Okay, that is curative treatment. I told you already, palliation is a common mode in our country. Palliation, what we do? Stent insertion. Okay, we'll come to that later. There are other palliation also. Radiotherapy is commonly done in our country. It can be a curative intent or a palliative intent. Externally, you ask the patient to lie down in the couch. Well, let the radiation come from outside, external beam radiation, or you put the radiotherapy unit inside, okay, through a Riles tube also. That is a brachytherapy, local radiotherapy. Classical example of brachytherapy, anybody know already? CA cervix, well done. That is vaginal ovoid. They put ovoid-like thing into the vagina in a CA cervix. So brachytherapy, classical example. Oral cancer, brachytherapy. Occasionally breast cancer, brachytherapy. So brachytherapy is very, very important. But in our country, external beam radiotherapy. What external beam radio? What is the radiation unit? All of you know? Because patients know better than us sometimes. There are 2 radiotherapy units we have. Cobalt, okay? And next is unit is linear accelerator. Okay, now proton beam is also there, but if you know, it is a linear accelerator. That is the commonest thing. It is able to give you the focused. In other words, you need to make sure whenever we give radiotherapy, the esophagus alone should receive, or the tumor bulk alone should receive the cancer treatment, not the lungs or heart. This is, in other words, whenever you design a treatment, there should not be any collateral damage. See, whenever we give laser guided bombs, they give. Why they say Americans? There is no collateral. It is a precise. So precise radiotherapy is now possible thanks to this, all the 3D reconstruction of the tumor by using a preoperative staging CT. So all those things I am sure the oncologists will know, but at your level, if you know, the technology is there to give you a radiotherapy with the least side effect to the neighbors, especially the lungs and the heart. In other words, minimizing the collateral damage can be done by the best modality is linear accelerator or a brachytherapy. Neoadjuvant, that is, what is neoadjuvant? It is otherwise called upfront chemotherapy. Upfront or primary means before surgery. First chemo, then surgery or radiotherapy. You first give chemotherapy because blood supply is there for beginning, a good blood supply the tumor, so the patient is able to receive the dose will reach the tumor and will shrink the tumor like melting a snow. So that is what cisplatin can be used, or any cisplatin like carboplatin, cisplatin can be used very easily, okay? Sorry for the disturbance, I'm just switch off the phone for the time being, just giving you some breathing time. Right. So chemo radiation, both can be, like you start the chemo, same time you give the radiotherapy also. So that way also, that is the best treatment for C. esophagus. So coming to the surgery, because being a surgical class, I'll tell you, there are 4 surgeries we do. One name alone you remember, because it's maybe too much for you. One operation we normally do is here. For example, if there is a cancer in the lower end of the esophagus, we remove with a 5 centimeter clearance above and below through an abdominal incision and also extending onto the thorax. That is extending on the left side thorax like this. Okay. And then remove this and pull the stomach and joining. This is not commonly done. It used to be a procedure done, but what procedure we now do, one case you remember is, one name you remember for the rest of your life as far as the esophagus is concerned is Ivor Lewis. Ivor Lewis is a UK, that is actually from Wales. Okay, Wales, Scotland and England. These are the counties in UK. So Ivor Lewis is one of the surgeon, okay, in Wales, and he described a procedure wherein he made a 2-incision, 2-stage surgery. What do you mean by 2 incision? He made an incision in the abdomen. He mobilized the stomach. How it is possible? You know, there are 5 blood supply to the stomach. Now, I'm asking you some difficult question. You discuss with your friends there. If you are as a group, there are 5 blood vessels. Right gastric, gastroepiploic. Left gastric, left gastroepiploic. And short gastric. See, 5 blood supply. That's why highly vascular organ. Esophagus, do you know any blood supply? It has small blood vessels from the esophagus the aorta directly. Nothing specific to call, okay? Unnamed vessels for esophagus. Like a ureter also, unnamed vessels to the ureter. Whereas thyroid and stomach, 2 highly vascular. Next to our kidney or next to our brain, these are the 2 highly vascular organs, okay? Stomach, coming to the stomach again, you just ligate the left gastric and left gastroepiploic and short gastric. So this part is mobilized. So the stomach is now fed by the right side, right gastric, right gastroepiploic through all these arcades. So that's why the importance of the anastomosis around the organ. And you are able to pull the stomach. You see, for example, like a tube like this. During the process, you may damage the vagus. So there may be some obstruction to the passage of the food. That's why we always do a pyloromyotomy. That's why there is a small incision, pyloromyotomy, to improve the drainage of the food. So pyloromyotomy mobilizes the stomach through the gastric incision, stage 1. Next, we do the right thoracotomy. You may wonder, why not, sir, left side thoracotomy? What is on the left side of your chest? Students, you know, left side chest, we have the beating heart, arching aorta. Those will be hindrance to a surgeon to operate. Whereas the right side, when you open the chest, once the lung is collapsed, literally nothing. Only one vascular organ on the right side for a surgeon is what? Anybody? It is the arch of the esophagus vein. So if I ligate this esophagus vein, esophagus with no named blood vessel, it will be removed like a sebaceous cyst. Easy. In other words, the dissection is relatively simple if you have a proper access and proper control of the esophagus vein. Okay, so that's why right thoracotomy, not the left thoracotomy. If you know the fundamentals, the same principle you can adapt for other surgeries also. I'm going to explain later. Ivor Lewis procedure is a 2-stage. First you do, then close the abdomen, turn the patient to the side, left side, and right side open, and do the procedure, and pull the stomach and anastomose here in the chest. Esophagus, stomach, anastomose here. But what is the problem here? If there is anastomosis not done properly, if there is a leakage of the anastomosis, what we call anastomotic leak, is the nightmare for any anastomosis done anywhere in the GI tree. Maybe it's the esophagus, stomach, colon, anywhere. If it leaks, the contamination may happen in the chest, mediastinum, and patient might die. A beautiful long operation, failure because of anastomotic leak is fatal to the patient. That's why this operation is not favored by some people, because nobody wants to have their anastomosis hidden inside the chest. Better anastomosis is outside the chest, preferably in the neck region. That is what the next surgeon did. So this is Ivor Lewis. This surgeon is very nice surgeon. Okay, Oringer. What he did, he made an incision in the stomach like what we did before, but he did an incision not in the chest, but in the left side of the neck like this. And he was finishing operation here. Then he went on the left side of the patient standing there. He put his right hand through the neck incision as if he is putting the hand inside a small bucket. So he imagined the thorax, his whole hand, you know, your gloved hand, you can, it is about 15 centimeter long. Esophagus, most of the esophagus he can remove from one hand from above through the neck, one hand through the diaphragm from below by another surgeon. So it can be mobilized. Esophagus is mobilized through the hiatus because there is no blood vessel there. Blindly, with a leap of faith from your blind hand dissection, he has removed the esophagus. He has done the operation and then he pulled the whole stomach and made the anastomosis in the neck here. And if there is a leak, the leak is not happening here. It is happening in the chest. That is the beauty of this operation. The same operation can be also done by this person who said, you don't do it blindly like this chap, like this transhiatally, but you do what Ivor Lewis did through a right thoracotomy and abdominal incision, but don't make anastomosis here, but you pull the esophagus and make the anastomosis here like what the transhiatal surgeon did. So he did a 3-incision, 3-stage procedure, which probably is best of both worlds. In other words, Ivor Lewis operation is good, but the Achilles heel or the common problem with that operation is anastomotic leak, mediastinitis. Whereas here with the 3-stage operation, anastomosis is higher up in the neck so that if there is a leak, the leak is not in the chest but is in the neck. So there is a controlled leak, controlled fistula. So this is safer operation, not the best operation. But ladies and gentlemen and students, you know, we are now in the era of endoscopy and laparoscopy, not an open surgery, all of you know. So any operation at your level, undergraduates, you write only 2 headings: open operation, endoscopic operation, and laparoscopic operation. As far as the esophagus is concerned, endoscopic surgery is only for early esophageal cancer, like a Barrett's esophagus, only for Barrett's. That is precancerous lesions. Whereas for tumor, only laparoscopy and open operation. Open operation, I have already said, in that one, whatever you forget, never forget one person, that is Ivor Lewis. Okay. Now coming to the laparoscopy. It is not actually a laparoscopy, to be precise. It is, as it is written here, thoracoscopy, because you are putting the, instead of making a big incision like this, what Ivor Lewis did, you make a small hole in the chest, also small holes in the abdomen, like keyholes in the stomach and also in the chest. Mobilize the stomach, mobilize the esophagus, you can do the whole operation. May take few hours extra, but patient has less incision, obviously no pain, early recovery, early return to normality. So these are the benefits of thoracoscopy or laparoscopic surgery. If anybody asks you, you can easily tell: smaller incision, lesser pain, lesser morbidity, so early return to normality. Doctor, I'm a busy football player. I want to go back and play my country or my team in another week's time. I may have to return, in a month's time I have to play. Can you do it? Because when you do a thoracotomy, it takes 3 months to recover. Thoracoscopy, less than a month to recover. Okay, that's about just to give you an idea. Coming to the next one is prognosis, the last slide. You are happy to hear for esophagus. Whatever you do at the end of the day, you see the patient's histology. Okay, when the patient comes back after 10 days after surgery and come and see you, what do? You look at the pathology report, look at the stage of the disease, TNM. That gives you the prognosis, because, and also the grade of the tumor, poorly differentiated, moderately differentiated, and a well-differentiated tumor. Poor prognosis is poorly differentiated tumor. And the stage of the disease, if the nodal disease, of course, it is poor prognosis. And also if they are having nodes are involved by a tumor, or if the margins are positive, poor prognosis. So this is common for all cancer. So for carcinoma esophagus, carcinoma stomach, anybody ask you, what is the prognosis of cancer breast? If you ask you, you don't tell prognosis, immediately vomit out the numbers, you tell the prognosis of the carcinoma breast depends upon the stage of the disease and stage grade of the tumor, doctor. So you have some time. Then what do you mean by that? The stage of the disease is either Manchester staging, CA breast, or by TNM staging. And nodal positive disease, if it is present like axillary lymph nodes, poor prognosis. No axillary lymph node, good prognosis. Grade of the tumor, if they have a high grade tumor, that is poorly differentiated tumor, then it is poor prognosis. If they have ER/PR positive, good prognosis. Estrogen receptor, progesterone receptor negative, poor prognosis. Like that, each one has a different prognostic criteria, but we'll come to that later. But just here, all cancers, stage of the disease, TNM staging, grade of the tumor will tell you what prognosis. I told you already, esophagus, stomach, pancreas, take it from me, poor prognosis, less than 10% per 5-year survival. In other words, 100 patients today, 10 patients only will be there after the end of 5 years. So radiotherapy, yes, we can give. Chemotherapy, I told you already, yes, we can consider cisplatin and also 5-fluorouracil, neoadjuvant therapy. Okay, but I'll spend some time here, 1 or 2 words about the palliation, because actually this is what we are doing. Only for exam purpose, I have discussed so far in the last. Sometimes we palliate by just giving them palliative radiotherapy, or we used to do what we call a laser treatment also, palliative laser treatment. But nowadays we give organ plasma, but those are only for completion's sake. What we do day in and day out is placement of a tube, because you can either put a Ryle's tube with a difficulty and feed, but still you are only forcefully feeding the patient. Patient has to eat, at least drink. How can you do that? By putting a tube. So I can put a tube here, a plastic tube or a metal tube. If I put a plastic tube, it is every chance the plastic tube can perforate or penetrate and perforate, because you are using some force to dilate that area. So we used to put a tube called one of the commonest plastic tube we used to put 20 years ago. I'm talking about Atkinson's tube, Celestine tube. Sometimes even metal tube we used to put, Sotar tube. All those terminologies you will read in the Bailey and Love. They are only mentioned to be forgotten because they are it is all in the museum nowadays. The only tube, the only stent we put from today for the next few years, I don't think any better alternative is available the next, is self-expanding metal stent. Okay, it's not my name, don't take it, it's self-expanding metal stent. Because if you put a plastic stent, the risk of perforation is very high. Whereas self-expanding metal stent, because once you put it, deploy it, it will expand slowly in the next 24 hours, okay, with a radial pressure like that. For example, if I deploy it like this, there is a deployment mechanism. Metal is having a memory. It is a very, very peculiar metal. Okay, I'll tell you a little bit later. Okay, this particular stent, for example, various stents we put in it when the cardiologist angioplasty and put 1 stent, 2 stent, 3 stents in your coronary artery. Do you know the name of the stent or the metal in which, the alloy in which the stents are made? Anybody there? If you already know, think about it. I'll give you a fraction of a second. If you remember, if it is nitinol, it is the right answer. Nitinol, Nitinol. Nitinol. Okay, what is nitinol means? Niti means Ni, nickel and titanium. So it is made up of nickel and titanium, which if it is compressed, it will take away from the outer sheath, it will dilate to a predetermined diameter. This is the way. The best thing is for you to see this particular schematic representation. So what we do is, we go near the tumor like this, and there is an assembly in which the stent is in a crust position. So when you take the assembly or outer sheath like this, withdraw it, the stent will just dilate slowly. Okay, and because it is funnel shaped and both at the top end and bottom end, it will not migrate from the place where you And even if you don't put it in the right place during your process, you can always readjust. See, for example, the person is not happy at exactly according to that. So he is pushing it a little bit, then he is deploying. So deployment, what is meant? Deployment is precise placement. Deployment word from the dictionary, precisely you place it under radiological control, a self-expanding metal stand that will palliate the patient for the next 6 to 9 months until the patient lives and he enjoys whatever little you are offered in a glass, like a liquidized kanji or something. Okay, so that's about the palliation. But sometimes stents can give rise to some tumor ingrowth or overgrowth. That's why there is one more question. You know the stent composition. What is the composition? It is composed of a unique material, nitinol. Now you remember. And there are two types of stents. One is called uncovered stent. What is uncovered stent? As you can see here, the stent is nothing but a bare metal. In other words, the tumor can grow in between the mesh-like position. And after a month or two, the tumor may be inside the lumen again one more time. So uncovered stent allows the tumor to grow. So it is not ideal, isn't it? But the advantage of the uncovered stent is it will not migrate. But we are having a now problem of tumor growing inside. So in order to avoid that, we nowadays put a stent that is called a covered stent. So the classical indication for a covered esophageal stent for a carcinoma esophagus, take down in your paper, is malignant tracheoesophageal fistula. What do you mean by malignant? Imagine you have a patient with a carcinoma esophagus today. After some days, the carcinoma slowly will infiltrate into the trachea. So what will happen? Patient develops a esophagotracheal or a tracheoesophageal fistula. Whenever you try to eat, the food will spillage into the bronchus. So he will cough. So every time he is not only having a terrible dysphagia, but also will have a troublesome explosive cough. So if he has that, the best palliation is putting a stent in the esophagus with a covered stent. When you put a covered stent, the covering will prevent spillage of the any content from the esophagus into the trachea. So covered stent is the ideal treatment for malignant tracheoesophageal fistula. No radiotherapy, no chemotherapy. So only treatment of choice for malignant tracheoesophageal fistula. That is why the covered stent is very, very important. So now there are 6 take-home messages for all of you for the end of this chapter. One, from students, take it from me for rest of your life. Any elderly person presenting with progressive dysphagia, especially for solid esophageal cancer, unless proved otherwise. So what you do? Endoscopy biopsy is a test of choice. That is the only test. Whatever test you do, that is what going to prove the diagnosis. Histology is very important before we initiate the treatment. What next test is most important? CT scan and abdomen and chest, because that is a staging investigation. T stage, N stage, M stage investigation of choice. Treatment. Best treatment is chemoradiation, neoadjuvant chemotherapy or radiotherapy. Curative surgery like esophagectomy can be done if patient is fit enough. Okay. Palliation, if you are going to do with the what? Self-expanding stent, preferably a covered stent, not a feeding gastrostomy, because feeding gastrostomy only improves the quantity of the life, not the quality of the life. So if you remember that, I think that will be a very good summary and also conclusion remark. So let's stop here. We'll have about 5 minutes break with the mute. You can unmute yourself. You can ask question or you can write question. I'll give you 5 minutes break. I'll also have a glass of water. Rajaram, any questions in the YouTube or anybody wants to ask? Students?
Not yet.
Ajit, you can ask any question or anybody, administrators. Raksita, tell me, how is your daddy doing? You can unmute and ask question. or you want me to go slow? I can go slow. It may be the first day one. It is very exhaustive because we not only discussed the carcinoma esophagus, we discussed oncology as a whole, because you have a glimpse of how to take a history and about the radiology, radiotherapy and things like that. So that's why it took some time. Harshini, yes, you are raising your hand, you ask, yes, time for you to answer. Ask your question. Harini. You can ask any question. I think unmute yourself. You are still muted, I think. That's why I'm not able to hear. Unmute yourself.
I have unmuted, sir.
Unmuted Harini, have you? Okay. Yes. Did you find it useful, Harini?
Yes, sir. Yes, sir.
Yes.
Yes, sir.
Any questions or any clarification, or have you understood the chapter, as this particular topic already discussed with you by your professors, assistant professors in your college already, this topic? Or your first time you are listening to this particular topic on CA esophagus or approach to dysphagia? Is it the first time or second time for you?
So this is the first time, sir.
So for a first time, how much you are able to understand and grasp? You are able to understand the concept of taking history in a patient with a dysphagia?
Yes, sir, I'm able to.
Okay. You tell me one situation where patient will have painful dysphagia. If I ask you, give one cause for painful dysphagia, can you tell any example of painful dysphagia? Because I haven't given you the example for painful dysphagia. Corrosive stricture or corrosive poisoning, if a patient is having, or if the patient had a foreign body esophagus, then they can have pain in the chest and then dysphagia. Whereas a carcinoma esophagus, the chapter we discussed, usually they'll have painless progressive dysphagia. That is very important. Like whenever there is a pain, it is more often an acute pathology or an inflammatory pathology, never a neoplastic pathology. For example, carcinoma of pancreas, painless progressive jaundice. Bile duct stone, painful jaundice. Classical example is bile duct stone. Whereas painless progressive jaundice is a carcinoma of pancreas. So most of the time, we always have a perception, cancer means pain. Pain is actually a delayed symptom of cancer. So that you should understand. So painful dysphagia immediately should not come with the carcinoma esophagus. It's actually corrosive poisoning or a foreign body, or some inflammation like fungal infection of the esophagus called moniliasis also can give rise to adenophagia. Okay. So like that you have to keep on adding your clinical acumen as you read, but you have to follow some template. So my discussion today is mainly template-based approach. Anybody else you want to ask, please raise your hand or unmute yourself. Only if you want to ask question, please unmute. Otherwise, I am going to just go quickly.
Sir, one person having the question, sir. Kishore.
Yeah, Kishore, fire away your question.
Sir, good morning, sir.
Good morning, Kishore. Yes.
Sir, you have been telling that in entire GIT, in esophagus and anal canal, we came across squamous cell carcinoma.
Yes.
And in esophagus, in lower 1/3 or because of Barrett's esophagus, we can get adenocarcinoma also.
That's right.
So the treatment modalities which you so far described is same for squamous cell carcinoma of esophagus and adenocarcinoma of esophagus, or it varies, sir?
It is same. Actually, it's a nice question. You may wonder. See, only thing is we should know squamous carcinoma is more radio sensitive. Adenocarcinoma is relatively radio resistant. That is, those days are gone now. Now the radiotherapy units are so powerful. Now that is not important. But what is important is adenocarcinoma more amenable for surgery because it is the lower end of the esophagus, and also it is usually behaves like a carcinoma stomach, where the predominant modality of treatment is surgery. We take lower end of the esophagus more commonly for surgery, whereas upper and middle third of the esophagus, surgically also difficult to resect, and also they are more amenable for chemo radiation. Surgery is less commonly done. So surgery is less common procedure for upper and middle third of esophagus, and lower third of esophagus, like Barrett's adenocarcinoma, surgery is more common option. But at your level, pathology part alone, you discuss the classification. When it comes to the management, you treat the esophagus as a whole. Don't treat according to the histology. There is no need for you, because that's not the way we approach. We approach anatomically, not histologically. You understand my point, Kishore?
Thank you, sir.
Okay, good. Anybody else, Rajaram? From YouTube, any questions?
No, sir. Not yet, sir. Not yet, sir.
Good. Okay. Let me go through this, because even though this is more or less the time we set, I think we still better will finish. What is the audience? If anybody, I mean, I'm sure most of you, whoever is want to start, another 15 minutes is going to take to finish the achalasia, because I want to finish one symptom in a given day. Then that will take us to the next chapter. Then even though the first day, it took little longer than my anticipation because of the descriptions, and in which I have to go slow. Then only I can take you all along as a single unit. Because if I miss the bus, here the eye contact of me as a trainer and you as a trainee is little less. So that's why it took longer time, but I'm sure next time we'll catch up with the time. Let me go without much ado to the slide sharing and go back to the slides and mute everybody. Rajaram, I am going quickly and give the nutshell on achalasia, because achalasia is a short notes. It very rarely is an essay, so we spend not much time. Okay. One word about achalasia is the problem lies in the esophagus motility, lack of peristalsis of the esophagus, and also the lower end of the esophagus, LES, lower esophageal sphincter, or LOS, whatever spelling, is failed to relax. Failure of the lower, in other words, I am just about to come near the door should open automatically. That is what I am expecting. The door is not opening. In other words, the food is coming because of the peristalsis, the door has to open. Like defecation also, when the stool comes, the relaxation of the internal sphincter should happen and the external sphincter has to happen. If it is not happening, obstructive defecation. Same way here, it is an obstruction to the swallowing. So this is what happened in achalasia cardia. It is a failure of the lower end of the esophagus to relax. This is a peculiar condition also caused in a pathology called the South American trypanosomiasis or Chagas disease. Trypanosomia cruzi. People have to go and read. The one interesting thing is that here I told you already in the history, they'll have long duration dysphagia, intermittent dysphagia for several months, especially in a younger patients like 30s and 40s and 50s, not in elderly people. Intermittent, that is, they'll have only during the occasion, like whenever they go into some marriage reception where they want to eat, they'll find. And more for liquid. Okay, this is the classical difference, because here the problem is more neurological. And I already told there are 3 important signs, 3 important treatment. If you remember that, that is well and good. What are the 3 important investigation? All these headings I ask everybody to write, but nothing much to say. They may have anemia, they may have some electrolyte changes because they keep vomiting. Nothing much in the biochemistry, they'll be essentially normal. Radiology, I know if you do a barium swallow, I already described the typical smooth, short narrowing of the lower end of the esophagus. That is a bird beak appearance. In addition, you will see 2 more investigation important, but in addition to the bird beak here, they also will have one more classical finding in the esophagus in the barium, that is called the sigmoid esophagus. Because esophagus is not only dilated, for many, many years it's dilated, so it becomes tortuous. The one of the tortuous part of our bowel is sigmoid colon, like S-shaped colon. So it looks like as if it is a colon, unless somebody tells you. So because it's, you see the heart side, otherwise people say, this is sigmoid colon, it is in the chest. Don't say, it is a sigmoid like esophagus. Okay, it is not sigmoid colon in the chest. So barium swallow showing a sigmoid-like esophagus because of the dilated tortuous esophagus with a narrow short stricture, a classical advanced achalasia cardia. Never forget this radiology for the rest of your life. When you do endoscopy, in carcinoma esophagus is very, very important. Here, it is important only for one reason, I'll tell you. But what you see in the, normally esophagus has to be empty. For you and me, when we do endoscopy when we do, because you are also going fasting for 6 hours, so nothing will be there. But for all these patients, will have either fluid or food will be there always. So whenever you find, as you pass endoscopy in the esophagus is dilated, fluid or food filled, no peristalsis, the lower end of the esophagus is spastic, tight, then it is classical thing. One of the important differential diagnosis for achalasia is called pseudo-achalasia. What is pseudo-achalasia? It is a tumor in the lower end of the esophagus mimicking like achalasia in the barium. See, if you do a barium, it look like this. You think it is an achalasia cardia, and you go for operation, then it will be a tumor, then you had it. So what you do, all case of barium swallow, after a few days, you have to do a endoscopy, look this area carefully, the lower end of esophagus, to exclude the cancer, small cancer, mimic like an achalasia. That is the pseudo-achalasia that is called. That's why the surgeon will ask you a question. Okay, barium swallow shows achalasia cardia. What else you do? Next, you have to tell endoscopy. Why do you want to endoscopy? You tell, I want to rule out pseudo-achalasia. He'll ask you, what do you mean by pseudo-achalasia? Sir, pseudo-achalasia means is a small tumor in the lower end of the esophagus region that will mimic like a achalasia, and it will misdirect a surgeon to do a wrong operation. So it is always better to do a endoscopy before we submit this patient with achalasia for surgery. If you say that, surgeon will say, well done. Next procedure. Is it enough, or this is the only investigation? Barium swallow, undergraduates, right answer. Endoscopy, surgeon will say, okay answer. But if you are having a DM gastroenterologist, he'll say the best investigation for any achalasia cardia is manometry. So in other words, if MCQ comes in your NEET exam, best investigation or the most specific, take it from me. There is a sensitive and specific. Most specific investigation to diagnose achalasia cardia is one of these. Choose. I'll write endo ultrasound. Okay, endoscopy, barium swallow, manometry. There you'll choose what? Manometry. Okay, if you choose any of the three, you may think, oh, you got the right answer. No, manometry is the thing, because nowadays we do a manometry called high resolution esophageal manometry, where, as you can see in this diagram, the red means high pressure zones, blue means low pressure zone, like your thorax. Okay, green zones, medium pressure zones. This is when you give the patient a wet swallow. If you ask the patient to eat, put the pressure transducer in the esophagus. As a peristalsis progresses like that, we can take a picture. So the pressure in the esophagus is color coded. So what is high resolution esophageal manometry? If they ask you, you can tell. We put manometer, that is pressure transducer, in the esophagus at 5 centimeter intervals, sir. 15, 20, 25, 30, 35. Then ask the patient to swallow the saliva, that is dry swallow. Then ask the patient to drink up water, that is wet swallow. When they do, the pressure changes, isn't it, as the food or saliva goes. That gives you the color image. So that will give you a picture that is different from each disease. This is normal. I don't want you to interpret, only to know this color-coded manometry is the investigation of choice to diagnose and classify the achalasia to 3 different types of achalasia. That is called the Chicago classification. So manometry is specific to diagnose achalasia. Manometry is essential to classify the achalasia into 3 types. What are the 3 types? Don't worry. I don't think it is necessary for undergraduates. And there are 3 treatments available for achalasia. So what are the 3 treatments available for achalasia? One, of course, is the simplest treatment, that by schematically you pass an endoscopy, as you can see, pass a balloon and forcefully you dilate with the air under pressure. That is called pneumatic. Pneumatic means air balloon pressure, pressurized balloon, pneumatic balloon dilatation, like this. See, this balloon is looking like a dumbbell, and the balloon after dilatation looks like a banana. So a dumbbell shaped balloon will change into a banana shaped balloon at the end. Then, as you can see, a spastic esophageal sphincter will become a patulous or open lower esophageal sphincter. Now food fluid will go easily. This is a very simple endoscopic treatment for achalasia cardia. It is the treatment of choice till 20 years ago, not today, unfortunately, because this is a simple treatment, but recurrence is there. That's why the next best treatment we do is called Heller's laparoscopic myotomy. Heller's myotomy. Heller's myotomy is nothing but cutting the muscles of the esophagus. You open the abdomen, or you make pass laparoscopy into the abdomen like this. You cut the outer, what muscle? The longitudinal muscle, inner circular muscle. Both you divide, then expose the mucosa. So this is called myotomy. The Heller's myotomy is like one other myotomy you all know already. Do you know? Anybody? We do it for congenital pyloric stenosis. Congenital hypertrophic pyloric stenosis. Yes? Ramsted's operation. Ramsted's operation for a baby born with projectile vomiting. Okay, there you do a Ramsted's myotomy. Similar case is the Heller's myotomy. Is there any other myotomy we do in the surgery? Only there are 4 myotomies. Remember now. One is Heller's myotomy, take down, for achalasia cardia. Ramsted's myotomy for congenital hypertrophic pyloric stenosis. Third, internal sphincterotomy for fissure in ano, painful defecation. Fourth, bile duct sphincterotomy for obstruction or stenosis in the lower end of the bile duct, maybe due to stone or because of the stenosis of the sphincter of body. So there you do a sphincterotomy. There all we divide the muscle. And also the fifth one, if you want, even you can add episiotomy. See, episiotomy to deliver the baby, relax the vaginal. So there also it is a dividing the muscle. So surgeons divide the muscles. So this is the classical example. So if you, this is what we call the association. You need to associate all this in your brain, so that whenever a surgeon calls you any other myotomy, you know, don't stare at him. You have to tell, sir, I know 4 different myotomy in addition to the Heller's myotomy. What all that? Because surgeon might do only one more, like Ramsted's. If you are able to tell like a sphincterotomy, internal sphincterotomy because of the for the piles, the fissure, or even episiotomy, then he'll really appreciate your brightness and the spontaneous, your swift answer. So that's the importance of knowing everything, and in by it will be always it will be coming to your rescue. So that's about the Heller's myotomy. And the third, the last 5 to 6 years, we do a procedure. I told you already, whenever we do any procedure for any disease in surgery, it is open procedure, laparoscopic procedure, and endoscopic procedure. 3 headings if you write, that is, and put it in front, open myotomy, or laparoscopic myotomy, or endoscopic myotomy, the surgery. If you know Heller's myotomy word, then you get a good mark. But the right terminology if you use, then you have an additional mark. For example, the endoscopic myotomy is otherwise called POEM. What is POEM? Percutaneous esophageal, okay, endoscopic myotomy. That is per oral endoscopic myotomy. You pass the endoscopy into the esophagus. At 25 centimeter level, you make a small incision in the esophagus. You create a tunnel in the submucosal plane in the esophagus. So this is called a third space or a submucosal space. You go down in the submucosal space into the lower end of the esophagus, right up to here. Then from there, you start dividing the muscle, and the mucosa is not divided. The mucosa acts like a flap, so that you divide only the muscle. Then where you made a small hole in the mucosa, when you finish the procedure, you put a small clip or a suture to close it. So you do the whole procedure of myotomy just through the oral, peroral endoscopic myotomy. This is the procedure of choice nowadays for achalasia. So the treatment differs accordingly where you are and when we were. So 20 years ago, balloon. Later, laparoscopic open Heller's myotomy. Now it is endoscopic myotomy. So you have to know all those things. Couple of small words about two essential emergencies as a resident you'll be coming across to close the chapter for today. That is foreign body esophagus in a child. For example, you may have a 5-year-old, your niece or nephew, if they are very small, they have a fond of playing with the small toys like a button batteries or a coin like here, they may swallow, come with the difficulty in swallowing. And if you do an X-ray, it will show you the foreign body. How do you know whether the foreign body is in the esophagus or trachea? If we ask you, you tell one answer to the examiner. I do always X-ray in 2 views, sir. Why? Because AP view and lateral view. X-ray neck, X-ray chest, X-ray abdomen. Especially X-ray chest and neck should be AP lateral view. Why? Because AP view only will tell you that there is a foreign body or not. Where exactly, you know only in the lateral view. Because lateral view will tell you whether it is an anterior mediastinum, medial mediastinum, or a posterior mediastinum. Here, for example, if you carefully see, we can see the faint air shadow of the, here you see the tracheal air shadow. Where my arrow is going is the tracheal air shadow. This is the periesophageal shadow. So the coin is actually in the esophagus, not in the trachea. Okay. And the other thing is, if it is the trachea, the child will be having not difficulty with swallowing. He'll have difficulty with breathing. So you should know, stridor will be the presentation if any foreign body in the trachea. Dysphagia will be the symptom if it is in the esophagus. Next important thing is, if you do an AP view, if a coin will look like a round coin. Coin looks like coin in AP view. Because if it is in the trachea, the coin in the AP view, trachea being a triangle shape, will look like this one in the AP view. In the AP view, if you see a round shadow, you can always say it is a coin and it is in the esophagus. But the lateral view is much more accurate and endoscopy will be confirmatory. But two foreign body, one has to be very, very careful is, one is of course a button battery in a child because it is releases alkali, it will damage the esophagus. Next is a sharp foreign body like a hairpin because that will cause perforation or a fishbone. So these are the foreign body. If you see, you have to immediately call a person, endoscopist, to remove it. Otherwise, you better remove it within 24 hours. So this is the some words about this. And just to give a glimpse, say for example, this chap came to me few months ago, having swallowed a small teeth with a denture. See, you can see a denture here in the esophagus, and he presented with acute dysphagia. 12 hours dysphagia. We took an X-ray, AP lateral view. We saw the foreign body, endoscopy done, removal done. So treatment is almost always no laparotomy, laparoscopy. It is always endoscopy. So treatment depends upon the condition. So foreign body removal, always endoscopic removal. Okay. Here, for example, again another case where we are able to find out the foreign body was removed, but underneath the foreign body, we find a patient presenting with a cancer. So what is the message I wanted to deliver? Any elderly patient, if they come with a foreign body, then don't just remove the foreign body. After removal, you go and do a completion endoscopy because until now, patient was swallowing. Because of the gradual narrowing of the esophagus because of the tumor, now he is not able to swallow even a small pea. For example, he is having a small pea or a mutton piece is stuck now because mutton piece, once it's swallowed, it should go through the esophagus. Why it is stuck? That means he is having a stricture in the esophagus. So underlying malignancy or stricture may be revealed if you do a completion endoscopy. So don't just remove the foreign body come out. Always carry on and complete the examination. So like for example, when you have a patient with appendicitis, we do a laparoscopy, appendicectomy. What we do? We just don't remove the appendix. We have a complete thorough examination. Look for Meckel's diverticulum, look for ovarian cyst, look for ectopic pregnancy. Like that, completion is always necessary. Otherwise, there is always a chance a patient may present with two pathology at same time, synchronous lesion, I told you. So here, this patient has a foreign body and also cancer. If I have just removed the foreign body and with a tumor in, he'll come again later with the advanced disease. So this is the take-home message. The last one is corrosive stricture. The penalty of drinking any of this because of the suicidal or accidental impulse, acid or alkali, will lead to damage to your esophagus. And what is dangerous, if you ask me, acid is dangerous because it is very pungent. It causes coagulative necrosis to your esophagus. But alkali, because it is tasteless, odorless, you tend to drink more without knowing its dangerous nature. So it sometimes causes the whole esophagus melt like a blotting paper. That's why it is a liquefaction necrosis. Very, very important terminology for a corrosive stricture. I want you to understand. Acid causes coagulative necrosis, C for C. Alkali causes liquefaction necrosis or a blotting paper like thin water. The esophagus baby perforation is very common in alkali. So L for alkali. And what is, so acid actually, even though it causes coagulative necrosis, it actually causes more damage to the antrum of the stomach. So it is actually acid licks the esophagus, it bites the stomach. So which is so common, acid ingestion is common in our country. It causes damage peculiarly to the antrum of the stomach, A for A, you remember that, okay? And anybody after ingestion of acid or alkali will come to the emergency department with odenophagia or burning sensation, drooling of saliva and stridor because he might have spilled the acid into the chest also. You do an endoscopy if possible, but a CT abdomen and X-ray chest, these are the investigation we do, and we always treat the patient with nil oral to start with because we don't know how much damage has been done. The definitive treatment is done little later, okay? Because I am already running out of the time, I'm going quickly. This is also not an important chapter, but the education is always how to prevention is better than the cure for corrosive poisoning. You ensure both in the house or wherever you are, don't put acid and alkali in the Pepsi or honeydew or all these bottles because children very easily get access to this bottle and they get into trouble. So put them in safely in a cupboard. So that is the educational message because acid and alkali poison is more common accidentally in children, suicidal in the adults. Okay. Now I am going to throw 5 questions for all of you. So all of you have a piece of paper and answer these 5 questions. Essence is very simple. If you get 5 out of 5, that means you have listened, you have understood, and you are 100% chance of getting through the exam. If you are 3 correct, that means you are an average student, you are okay, and if the with interest and the inclination, if you go for the next 30 modules, I can assure 80% chance of you are clearing. If you are only 1 question right, that means you have to go to the YouTube and read this again or refer to your book. So 1, 3 or 5 or in between. Let's see, and you are the judge yourself. Okay, here is the best test for pre-operative staging of CA esophagus. Pre-operative staging, which is the one? Barium swallow, endoscopy biopsy, endoscopy ultrasound, CT abdomen and chest. Don't discuss with your colleagues. You choose it in your mind. Your answer, if it is number 4, that is the right answer. Next, achalasia cardia, failure of lower end of esophagus to relax. What is the most important test of choice, investigation of choice? Barium swallow, endoscopy, manometry, CT abdomen. If your investigation choice is manometry, then you are right, absolutely. Next, Ivor-Lewis esophagectomy. I have made 4 statements about the esophagectomy Ivor-Lewis. I have written one wrongly. Find the wrong statement. Ivor-Lewis esophagectomy is indicated for CA esophagus. It is a two-stage, two-incision esophagectomy. It involves left thoracotomy. Risk of mediastinal sepsis due to anastomotic leak is present. Which is the wrong statement? If I choose number 3, because I told you left side you have the pulsating aorta arch and also beating heart, difficult thoracotomy. So Ivor-Lewis explained right thoracotomy. So left is the wrong. So 3 is the wrong response. The next one is you say true or false. I am making a statement here. Barrett's esophagus predisposes higher incidence of squamous cell carcinoma of esophagus. True or false? Whether it is a predisposing to CA esophagus squamous cell. If you choose true, that is a wrong answer because it is false statement. It only predisposes to columnar cell carcinoma. Okay, the statement is false. Okay, next, true or state. Acid ingestion causes more damage to antrum of the stomach than esophagus. Your choice is true. The statement is true because I already said it only licks the esophagus, it bites the antrum of the stomach. Okay, I think now we have the next module. We'll have, if there is any announcement or any important festive day, we may have to, in exceptional circumstances, we cancel on Sunday. Otherwise, we make it as a ritual to assemble sharp at 11 o'clock every Sunday, if you're all agreeable. If any comments or anything, I require the coordinator to put it, whether it is too long or you want me to go a bit slow or any other comments or constructive criticism, put it there or put it in the YouTube, we'll read it, or my colleague Rajaram will feedback, give to me. So accordingly, we'll modulate the timing, speed, style of presentation next time. Next, of course, is dysphagia. So that will give you some idea so that you can go and read and come prepared. Okay, and come early because if you are beyond 100 participants, of course, you may have to go into the YouTube link where you may not ask directly by chatting. Now, Rajaram, unmute everybody for 5 minutes question time.
Yes, sir. Sir, Kishore having the question, sir. He
Yes.
His hand.
Yeah, I'll just stop sharing this. Sorry.
Kishore. Mr. Kishore. Okay. Sir,
Hello.
another person asking questions. Roja Srinivasan. We can talk, madam.
Yes.
Hello, Gogulnath. Gogulnath, sir.
Any questions or any clarification? Even if it may not be a question,
Yes.
somebody would have understood, but I don't want anybody with different understanding. Like for example, the last 15 minutes of the achalasia, I was rushing a bit because I know I took some more time than what is necessary, but I want to, in essence, complete the whole module. That's the way we can go into the, every day we start with a fresh module rather than middle of a module. It is not right. Next time we'll time it such a way, 90 minutes, bang, we'll finish it. Okay. Yes, any questions? Couple of questions to conclude the session.
Sir, I have 2 questions from YouTube viewers.
Yes.
One of the question asking by Guru Jyoti.
Yes.
For carcinoma esophagus, which treatment is better? Either palliative or chemoradiation, sir.
Okay. See, any cancer, you have to write 2 things. See, you are undergraduates. You are not going to be designing the cancer treatment for us. So every treatment you have to see it is a multimodal, multidisciplinary, individualized treatment. That line has to be done in all cancer patients. Okay, take down from me. Multimodal, you write next is surgery, radiotherapy, chemotherapy. In surgery, it could be palliative or curative depending upon the stage of the disease and operability of the tumor. See, these are all the statements. It will be common for all conditions. You write that one. And it is a multidisciplinary. What is multidisciplinary? All cancers nowadays, we assemble like a board, tumor board. Tumor board means a surgeon, oncologist, and a pathologist, and also the cancer sister, like an oncologist sister, and a radiotherapy unit, palliative physician, psychiatrist, sociologist. There are so many people in abroad. There are 10 people. They sit together. This patient is an elderly man. For example, I'll tell you, 86-year-old man, okay, living alone, having an advanced disease, may have a different treatment. A 40-year-old man having a fit heart, and he is very fit athlete. He is having an early T1 stage of tumor. Treatment is different. So the treatment is custom made or individualized depending upon the patient's stage of the disease and performance status. So all those things are, you are not going to design. So as an undergraduate level, you have to write the principles alone. That's why I'm telling you, you write the cancer treatments. They're all individualized, involving multiple modality, multiple discipline. And then in the multiple modality, cancer, curative and palliative. In cancer esophagus, because very often in our country, our advanced stage, more people go for palliative treatment. 60 to 70% we do palliation only. If you want a statistics, only 30% go for cure. In the cure, there are two options. One, entirely chemo radiation, no surgery, and surgery alone. It depending upon the unit. For example, if you are going to the Tata Memorial Hospital, they aggressively they treat, like they give chemo radiation, then operate. For example, if they come to some places in our setup here, we'll do 80% of them chemo radiation, because radical radiotherapy in our setup gives equal treatment, because surgery is very major surgery. See, when it comes to carcinoma stomach, colon, surgery is the best treatment. CA breast, surgery is the first best treatment. CA esophagus, chemo radiation is the safe best option. Even though we spoke so much about Iver-Lewis esophagectomy, only about 30 to 40% of the people will be going for that. Most of them will not go for that. Only chemo radiation. So it is very difficult at your level without seeing more paper to understand. So you write only in the exam and even in the Viva, tell the principles to the examiner. That's what they expect from you, not custom made for a given patient. It is very difficult at your level. Okay, thank you.
So one more question from YouTube viewer from Raj Ganesh.
Yeah.
How to differentiate dysphagia for liquid and solid between achalasia cardia and carcinoma esophagia?
Yeah, see, dysphagia is progressive, very, very important. In other words, in carcinoma esophagus, you allow the patient to talk. If you allow the patient to talk, he will have typically, see, imagine I am the carcinoma esophagus patient, I'll tell you, sir, I've been having this problem with my swallowing, like if I eat, the food gets stuck somewhere here. And 3-4 months ago, I was able to eat even mutton, chicken you offer me, I will take a little time, it takes some extra time. But lately, the last 1 month, I avoid all the mutton, chicken I offer, no. I'll only take something like a egg white or liquidized, semi-boiled egg, thing like that I used to take. See, for example, the last 3-4 days, even that is not going. Only a little bit of fruit juice. Even that, if I just filter it, it goes. And also it stays there for a long time. I feel I have to do this way. Or if I only take like a Pepsi or some carbonated drink, then only it goes down. So he'll construct the history in such a way, progressively he'll say, near normal diet, semi-solid, then liquid, now even saliva he finds it difficult. That is the construction. It is progressively it will go. But in this patient, for example, achalasia will say, Doctor, dysphagia. Yeah, I used to have a difficulty with swallowing sometimes. It was last 3-4 years I've been having this problem. Not always, doctor. 1 month it is there, 1 month I'm all right. Because these people think that is normal for them. Because having food here, they'll have a dilated esophagus filled with food there. Every time they eat okay. It'll stay there. When they eat the next meal, the previous meal, because of the hydrostatic pressure, it will go in. It is not, there is no mechanical obstruction. It is neurological problem. After some time, it will be empty. So what they'll do is they have to drink. That is, they have to drink a lot in order to eat. For 1 idli, they have to drink 1 liter. Like that, they have to drink a lot of liquid in order to push even a small amount of solid food. That's why they say the difficulty with is not actual difficulty with the liquid. It is apparent difficulty of having to drink a lot of liquid in order to push the food down, and it's intermittent in nature, non-progressive. The only thing is sometimes they apparently, most of them, they remain also of same weight. The only thing will distinguish is they'll have definitely nocturnal coughing, they'll have halitosis, and they'll come to pulmonologist with a recurrent chest infection. Very, very typical history in achalasia. Okay, next. Any other question? Otherwise, we'll conclude, Rajaram.
Yes, sir.
Yes.
Any
Okay.
participants?
Yeah. You conclude. You do the kind of remark, and I'll do the closing. Okay, I'll do. Ladies and gentlemen, and my dear students from all the medical colleges, I'm sure more than apart from the Perundurai Medical College and Coimbatore Medical College, I think there are people, as I can see, from other medical colleges, not only across the state and also from various other states also going to join in. It is a collective effort, not only to fight the COVID-19 crisis. I think this gave me an opportunity to interact with you and gives me an immense satisfaction because we do teaching the postgraduates and my post fellows, that is specialists in super specialty also, but it's nothing like grooming undergraduates. That's a real challenge because you are in the stage where you have too much of information thrown at you, and it's very difficult for you to know which one to filter, which one is essential, and make it very understandable, easy to swallow. So that is a challenge posed to me, and we are going to take the challenge and able to go through this in 30 challenging modules, and we are very, very happy to finish the module. What I'm going to do today, if not in the next few days, I'll be sharing you a PDF of this particular topic also written as an approach to dysphagia, because we have come out book, a small book, handbook of surgery. I think Rajaram, you can share that PDF version of that particular chapter. I'll tell you later. You share it, but for the time being, you can share the first page of the book and where you can get the book. If they want to get the book, you can post them also the book on the cost basis, or the chapter alone we can give them a free to download later. So these are the two services we are doing on behalf of Lotus Hospital and IAGS. Goodbye for all of you. Have a peaceful Sunday today. See you next Sunday. Thank you very much. Bye bye all.
Thank you, sir.
Okay, thank you.